All right, good morning. First patient is a 57-year-old female who fell down 2 stairs and sustained this right distal radius fracture. She was neurovascularly intact. She has a history of MS. She was closed reduced and placed into a sugar tongue splint. Next patient is an 87-year-old female, status post ground level fall with a left distal radius fracture. She was closed reduced and placed into a sugar tongue splint. 43-year-old female, status post MVC with a right Weber A ankle fracture. She was neurovascularly intact, placed into an air cast and made weight bearing as tolerated. Next patient is a 76-year-old female, status post ground level fall from a counter while dusting. She was admitted to the SICU for rib fractures and a pneumothorax. We were called on hospital day 3 when they noticed she had pain with ambulation. They found this left 5th metatarsal distal shaft fracture on imaging, and we were consulted. She was neurovascularly intact, made weight bearing as tolerated, and placed into a hard sole shoe. Next patient is a 61-year-old male who fell down a couple rungs of a ladder and had sustained this left calcaneus and left proximal humerus fracture. Patient was neurovascularly intact. He was placed in a sling to his left upper extremity and then a bulky dressing to his foot. And then he will follow up for possible surgical planning for his calcaneus. My guess is it'd probably be like a Sanders 3. I guess you could possibly argue it's a 4 with a comminution. So.
Good morning. First patient is a 68-year-old female, status post fall with a right hip intertrochanteric fracture. She was taken for a right hip intramedullary nail. Next patient is an 86-year-old female, status post fall with a left hip intertrochanteric fracture with a reverse obliquity pattern. Taken for a left hip intramedullary nail. Next is a 62-year-old female, status post fall with a right femoral neck fracture. It's taken for cannulated screws. Next is a 74-year-old male, status post fall with a femoral neck fracture. Also taken for cannulated screws.
You want to describe his fracture, how that's different from the other one?
Sorry. So the first femoral neck fracture, I would say, is maybe minimally displaced on the AP view. So that would make it a Garden 3.
So what do you think about the in the sagittal plane, the angulation of that fracture? Is there any apex anterior deformity?
I'm sorry, would you repeat that one more time?
So look at the frog lateral. I mean, do you think there's any sort of posterior angulation to the fracture or not?
Yeah, I could see that. There might be a little apex anterior there.
That's kind of what I was getting at. The one was sort of impacted posteriorly and the other one's classically impacted in valgus, both of which you can put screws in, but you got to be careful with that one that goes anterior because you can miss how displaced it is.
Why did you choose to use a short nail on the reverse obliquity fracture?
I don't think it matters whether you use a short nail or a long nail, as long as you get at least 3 to 5 centimeters distal to the fracture site.
Now that what you're quoting is the biomechanical, and there is a clinical study that says there's no difference if the fracture doesn't extend past 3 centimeters below the lesser trochanter. And that's just because the length of the typical nails is between 170 and 180. After 3 centimeters, you start seeing greater odds of failure.
How are you going to measure that 3 centimeters on that one, unless your trochanter is up near the ischium?
That's the problem for this one. But if you could guesstimate,
Sorry, Dr. Butler asked.
I can't hear shit if there's something going on.
Dr. Butler just asked if we would do anything different with the nail, given that it was a reverse obliquity.
If it was the little Butler, tell him to go pound sand.
All right. Okay. Next patient is a 46-year-old female status post fall with a left Triamount ankle fracture dislocation. Close reduce and placement splint. CAT scan revealed a large posterior malleolar piece. Patient was taken for an ankle ORIF.
Okay, and so the reason for doing that acutely is based on what?
Acutely, as opposed to doing like an X-fix, or?
Yeah, I mean, a lot of these will have big problems, you know, if you operate on them right away, and some of them don't. So how do you decide? Because it's still kind of a mystery to me, and I want to know what guys like surgeons and so forth have to say, because I'm still, this is one that perplexes me a little bit. I see guys get away with this all the time, and every time I try and do that, it pusses out.
the most ankle fractures can get done acutely. That the idea that, oh, it's too swollen, you have to take into account their kind of factors. If diabetic's too swollen, yeah, you probably can wait. If it's a vascular path or heavy smoker, anything that predisposes you to poor wound healing already, and then you take the swelling into account. It's never wrong to X-fix someone because you're worried about swelling, but a lot of the ankle fractures can tolerate acute ORIF. There's some theory about that. When you do the incisions, you kind of release some of that pressure that would have built up with assuming the fracture is closed. But that's not really proven. Plus the posterior lateral approach tends to have fewer wound complications than the direct lateral incisions for like the fibula, just because it has more soft tissue underneath.
Okay, so I had one person that was very large, one person who was a diabetic, but not a really bad diabetic. And so those you might consider going delayed, but an otherwise healthy person with an energy injury that wasn't super high, that's not something I have to be afraid of, right?
Correct.
Can you explain the screws that you used in the tibia, the posteriorly? Why is it looks like one of them is not in the plate and is cancellous, and one of them is cortical. They're both in the same relative location. Why didn't you put the plate below the fracture line and put both screws through, and why didn't you use cortical screws? Just a technical question.
Yeah, so the one that's not in the plate was a lag screw that we just wanted to fix the fragment with first, and then the plate was like an anti-glide plate to just prevent shearing.
Do you need both?
I don't know if you need both, but I think just given the size of the posterior mouthpiece, I think we wanted to get more definitive fixation there.
So you went bicortical with your cancellous screw?
Yes.
Okay. Was that just to gain better purchase than a normal fully threaded cortical screw?
It's a cortical lag screw.
It's not. It's a cancellous screw. But wouldn't it make more sense if you're really worried about it that you put a T-plate on and put a few screws in that, or at least have more than just one screw hole distal to the fracture?
Yeah, I suppose that could work.
I think you can do it either way. You can do it either way. Depending on the room back there, depending on how much you can, if you can get a T-plate at far medial, sometimes that's hard with soft tissue. A 1/3 tubular is fine. You can put a small T-plate or a bigger T-plate. So an anti-glide plate is the name of the game. Plus that lag screw works. Looks good to me.
No, the reduction is perfect. Is that the same concept for the fibula too? It was an anti.
Yes.
Okay.
All right, next patient's an 8-year-old female, status post back handspring with the left both bone forearm fracture. Close reduced, place a sugar down splint. Next is a 12-year-old female, status post fall with a right distal tib fib fracture. Was closed, reduced, and placed in a long leg cast. Next is a 78-year-old female, status post leaning out of a recliner with a left prosthetic hip dislocation. Just close reduced, placed an abduction pillow, posterior precautions. Thanks.
How long ago was the total hip?
It was 2013. Second time.
First one?
Second dislocation. Thanks.
So leaning back in a recliner, is that a usual mechanism for a posterior hip dislocation? Hip extension?
So she was in a recliner and then leaning to her right to try and get the lever to get out of the chair. So I think there was some like a flexion of the hip, and then she felt the pop.
Yeah, that would be a more typical mechanism for this, right?
Mm-hmm.
When was the first dislocation?
It was about 1 year prior.
So a question, just going back to that one for a second, 13 years ago and now in the last year, she's had 2 hip dislocations. I'm assuming that's bad mojo, right? She's torn up her, and I assume she went out the back. So She's torn up whatever was back there, scar tissue wise, capsule wise. This, you think, is going to become a chronic dislocator now, or needs to be revised?
Yeah, I think, given her first dislocation, she may have some laxity in the abductors and would be a good candidate for a revision.
Did you get inflammatory markers and potentially work up that aspect of the
Yes, we did.
etiology of
Inflammatory
dislocation?
markers were unremarkable.
Well, then Bayonne can't fix it. That's too bad.
Bayonne can always still fix it.
Good morning. First case is a 60-year-old male, status post fall from a cherry picker, roughly 20 feet, with a right open elbow fracture dislocation, a right distal radius fracture, and a left first metacarpal base fracture. He was neurovascularly intact. Other injuries included right 2 through 4 rib fractures, as well as a nasal bone fracture. So initially he was taken that same day for a right elbow IND, open reduction and repair of the MCL, given that the laceration was on the medial side. The CT scan was obtained after that first procedure, showing a comminuted displaced radial neck fracture, as well as a cornoid tip fracture. He was then taken in a staged manner, first for a right distal radius ORIF, a left first metacarpal base, closed reduction percutaneous pinning, and then a right elbow internal joint stabilizer with a radial head replacement and repair of the LCL. This is a 42-year-old.
What was fractured besides the radial head and the tip?
Radial head, there was a coronoid tip avulsion, kind of a small tip fracture.
Okay.
No, we just kind of avulsed as like a sleeve, so we just repaired it back over the JS. There's the suture anchor was in the MCL. This is a 42-year-old male that we discussed last week, was a polytrauma. His pelvis fractures were presented last week, and we briefly discussed that he had a left traumatic ulnar translocation of his carpus that was initially noted on X-ray, and then he was tender there as well. An MRI was obtained, motion degraded, but also shows some volar ulnar translocation of his carpus. And he was taken for a radiocarpal percutaneous pinning, as well as repair of his volar ligaments. This is a 20-year-old male.
So what did you see? Can you tell us what you saw, since almost nobody ever saw this before? Yeah,
it was interesting. So we took him maybe 6 days after the injury, and we're expecting to see, a lot of hematoma and swelling, and that's not really what we encountered. It was his radiocarpal joint was grossly lax. All of the volar ligaments were torn. So we were able to kind of just shift the carpus back radially, get a good reduction and pin it there. And then we just kind of repaired what we could of the volar radiocarpal ligaments.
Well, which ones did you see, and how did you repair it? I don't see any anchors in there.
Yeah, so
where was it torn?
There were like mid-substance tears. We repaired the radioscaphocapitate, as well as the short radiolunate, and I believe the ulnolunate as well.
So
everything was sheared at the radiocarpal articulation. There was no midcarpal problem, which was unusual. The space of Poirier was normal, and the whole carpus shifted together, and it was chronic. I mean, it was old. I mean, there was nothing in there that determined that there was any acuity to that injury at all. Not the least of which, he was complaining about his right hand that was weak because he had a plexus injury, and his left hand, he had already ripped the splint off and was using it to grab for food and stuff. Like, it wasn't bothering him at all. It's weird.
So this was not an acute injury?
This was definitely not an acute injury. This guy's a chronic motorcycle crasher. And he did this at a prior injury and was either undiagnosed or, you know, and against medical advice management of it. I don't know.
How long you leave the
So
pins in for?
This guy's,
Well, let's assume it was acute, just for the teaching purposes. How long would you keep the pins in?
So I some of the papers I read, like 6 to 8 weeks, keep the pins in, and him maybe even longer, as long as they weren't causing any skin problems.
Right. So the point in him, I don't know that it matters if it's really chronic. You're not going to
Right.
really do anything. But if you have to keep it in for 6 to 8 weeks, it looks like you curl the ends of those pins. Are they buried or are they not buried?
They are not buried.
All right. So anytime you leave pins in and they can come out in less than 4 weeks, you can leave them outside the skin. But after 4 weeks, you're better off burying them so that you don't have to worry about them having a pin tract infection. So in this case, probably doesn't matter. And maybe you spoke about that in advance, but whenever you do an intercarpal repair or a radiocarpal repair, you have to count on 2 to 3 months for that to heal.
Tell me about
Yeah,
those pins.
we had that discussion.
Yeah.
So like that ulnar pin, just in terms of the trajectory that you're using, you're kind of starting, you know, mid-lateral, kind of grabbing the hamate there and then putting it into the radius.
Yeah.
Okay. What nerve's at risk right there?
Oh, the ulnar nerve.
Yeah, I think that's a good point. The dorsal ulnar sensory branch. And then especially when you start going on the sides of the wrist like that, and I think this is the only way to do it. But one little trick here that I've started using that has helped out is when you insert those, do it on oscillate. So there's less chance you can wrap up either the sensory ulnar branch or the radial sensory branch.
Gotcha. This is a 20-year-old male status post last basketball injury with a right middle phalanx volar base fracture subluxation. He presented to us 2 weeks after this injury, at which time we took him for a close reduction percutaneous pinning with an extension block pin.
How would your management have changed if that was acute?
Can you?
Yeah, so if it was acute, I think it's a good candidate for close reduction and dorsal block splinting. You know, it's certainly less, I would say less than 30% of the articular surfaces involved.
Were you able to close reduce the joint? Was that easy to reduce at 2 weeks?
We took like a towel clip and were able to get a pretty good reduction and fire some K wires across volar to dorsal. This is a 40-year-old female status post fall downstairs with a right distal radius fracture. She was initially close reduced, placed into a sugar tongue splint. She followed up about a week later in the office and had lost reduction. Unfortunately, I do not have those x-rays, but she was taken to the operating room for a right distal radius ORIF.
As an aside, we presented one of those, I think it was last week or the week before, and David Kirschenbaum, you had mentioned that we didn't have good fixation in the radial styloid. I've seen that lady back and follow up, and as you had predicted, it's started to shift a little bit. So she's got fixation and a cast right now. Yeah, some of those are a little bit more challenging than others.
This is an 88-year-old male status post fall with a left hip intertrochanteric fracture. It was neurovascularly intact, medically optimized, and taken for a left hip intramedullary nail. Last one is a 95-year-old female status post fall 5 days prior with a left distal radius fracture. She was neurovascularly intact, close reduced, and placed into a sugar tongue splint.
Morning.
If that's your
Perfocation.
grandma, don't reduce her. That's just going to be painful. She'll be fine.
First patient's a 19-month-old male, presenting after a fall from his bed with a left both forearm fracture. Patient was neurovascularly intact, was reduced and placed into a sugar tongue splint.
Is that acute? It looks like there's, or is that just how he broke at the original films?
I'm sorry.
Just not a complete. Okay.
Oh
never mind.
yeah.
Because it looked like maybe it was a
Fracture.
healing fracture.
Next patient's a 89-year-old male, presenting after a ground level fall, the left hip intertrochanteric fracture. Patient was medically optimized and taken for a left hip intramedullary nail. Next patient is a 62-year-old male, presenting after an MVC with a C4 spinous process fracture.
Speak up just a little bit, please.
Sorry, 62-year-old male, presenting after an MVC with a C4 spinous process fracture, left C5 superior facet fracture. Patient was neurovascularly intact on this presentation. MRI was obtained and no ligamentous injury was noted. So decision was to treat the patient in a hard collar. Patient presented to the office 10 days for routine follow-up, and these radiographs were taken showing displacement of the fracture with subluxation, the C4-5 facet, and a traumatic spondylolisthesis of C4 on C5. Patient was sent to the emergency room, and CAT scan was obtained to further characterize the pattern, again showing this subluxation of the C4-5 facet and traumatic spondylolisthesis. On this presentation, patient was noting some deltoid weakness on the right as well. Yeah. Yeah. Yeah, you can see that it's perched. So the patient was taken to the operating room for a C4-5 anterior cervical discectomy and fusion.
And do you know the failure rate for non-operatively treated unilateral cervical facet fractures?
I don't know the rate, but I do know that it's, there's not really very good treatment options for, once they're subluxed. I know, there's different options that you can treat them with. You could do a halo vest, but that's, pretty morbid and in elderly population has pretty good or pretty poor outcomes in general with these type of fracture dislocations.
Yeah, so I mean, so if you come in the joint sublux, the vertebrae is listhesis, the facet is dislocated or perched, that should be treated surgically every time. But on initial presentation, it was a unilateral facet fracture. It was non-displaced. There was no subluxation or listhesis. So that is appropriately treated non-operatively. But I think the recent studies I'm familiar with quote a 20% failure rate even for those. So 80% will be treated successfully in a hard collar, but 20% will still fail. And then there's sort of a predictive tool you could use. They say you can measure, if you measure the height of the facet and then you measure the height of the fracture fragment, they say if greater than 40% of the facet is involved, failure is more likely. In this guy's case, it was maybe about a third of the facet, maybe 30%. So I'm surprised he failed, but nonetheless, he failed.
Was it reduced before you did the anterior cervical discectomy infusion, or did you reduce it on the fracture table?
All we did was put him to sleep, extend his neck, and it reduced.
So should that be fused in kyphosis, neutral, or lordosis?
It should be fused in his normal alignment, which is a small amount of lordosis.
Because it looks like it's fused in kyphosis. Yeah.
It's like there's some lordosis in there, some normal lordosis.
The alignment is much better post-op than pre-op.
I don't know. Looks good to me.
Yeah, I'd take that any day of the week. You don't want to overload those them, because then you can narrow the framing too much.
The toughest part of these cases is actually not to overstuff the disc space. So we took the smallest graph that they had, and it's still if you look at the height of that disc compared to some of his adjacent discs. So
does the height of the disc determine the lordosis, or does the contour of the plate do that?
It's sort of a combination of factors. The amount of lordosis in the graph can impact it. The contour of the plate can impact it. Sometimes these just go where they want to go, and you accept what you get.
Thank you.
Spine surgery is so easy. You stick a little bone graft in there and a plate on it. Easy peasy.
Yep, just don't put it in the wrong place, Tim.
Wrong levels are bad.
Yeah.
Good morning, everyone. First, we have an 11-year-old male, right hand dominant, stats with fall while playing soccer. He's in his left distal radius fracture he's close reduced, placed into a sugar tongue splint. Next is a 6-year-old female. She fell from the monkey bars. She had this left supracondylar humerus fracture. She was seen in the office, and then she was taken to the OR 2 days later for close reduction percutaneous pinning. Next, we have an 11-year-old male who's been by a dog. I've seen him in urgent care, and he presented to the office 2 days later with this left ring finger open P1 fracture. He was taken to the OR. He's close reduced, close reduced percutaneous pin. Notably, he had a ulnar digital nerve injury, which was repaired primarily in the OR that day. Next, we have a 15-year-old male, right hand dominant. This patient presented to us was presented previously in September for this both bone forearm fracture that was closed but not reduced acceptably. And was taken for flexible nailing. He presented in the office in the ensuing months, where he's found to 1 loss reduction, 2 had a blocked motion to supination. He couldn't get more than 5 degrees mechanically blocked. So he was taken to the OR, removed the nails, and then did osteotomy of the ulna and reduced that bone, which provided far more supination, and he was plated internally fixed.
Can you go back to the beginning? In the beginning, when you first fixed it,
yeah,
it's a 15-year-old, a big person, a little person?
Just a normal sized kid, 15-year-old, not average.
Growth plates are closed.
Yeah,
and after putting those pins in, the patient had normal rotation?
He was in a cast, and then when he presented,
he had normal rotation in the operating room. And, initially in retrospect, I should have plated him in the first place. But I used the flexible nails. He was 14 at the time. And, I felt that this was adequate, but he gradually lost reduction.
Which bone lost reduction?
I think that the ulna actually kind of developed an apex volar deformity. And then, I saw him in the office last week. He developed a bit of a bursa over the olecranon portal for the ulna pin, and I was going to take him back to take them out. Then I examined him, and he had a pretty significant block to supination. He had about 5 degrees of supination.
Are you routinely using these intramedullary devices with such distal ulnar fractures?
I have, but going forward, I will not.
Because you have almost no, pin in the distal fragment. It's just hard to believe you can maintain anything.
Yeah. In hindsight, I should have plated him.
think we use them all the time, but I think this kid's just on the older side, and it's probably at the distal extent of what you would consider. You know, if this were a younger kid and any slightly, you know, I probably would have done flexi-nails in a younger kid, but I think the combination of the age with the distal extent of it.
Is there any reason you didn't try to put 3 screws distally?
I think that, you know, in terms of, you know, the amount of space we had, and we felt that we had a secure fixation there. We ended up switching out the initial non-lockers for lockers in the end, and it was stable.
And is that a 3-5 plate?
It's a 2-7 plate.
It's a 2-4 plate, actually.
2-4.
And how big is the kid?
He's probably about 5'3" and a $120.
Okay, I would just say, I'm sure the fixation is stable. These will, you know, and it's a kid, so it should heal quickly. But it looks like you do have room for 1 more screw. You just don't want to ever have to worry that you're going to lose fixation.
Yeah, that Synthes 2-7 plate has many more holes comparatively, and I like that better, particularly for these distal ulnas. They are pain.
Yeah, the problem is his bone was not very wide, because these are striker plates. They did have T plates, just like those Synthes plates. They had them in both 2-4 and 2-7. I mean, he's a thin kid, even though he's 15. Like, you know, I just didn't think it was going to fit well. We would have had to bend it around, and we were already getting pretty distal. So I thought that this fixation was acceptable. It was stable. We stressed it in the OR. You know.
Yeah, it's probably going to be okay. You're going to put him in a cast anyway, right?
Yeah, he's in a cast right now.
So what was blocking his supination? I assume it was the DRUJ.
Yeah, so as soon as we kind of did the osteoclysis and had that distal ulna mobile, we were able to push it volar and reduce it, and he had full supination while you held it in that place. So I think it's just that his DRUJ was dislocated, honestly. He had a hard blocked motion that was not going to get better with time, in my opinion. But that's why we also decided to only do the ulna. Once we had reduced the ulna, we had full supination and full pronation. So I didn't think there was any benefit to us fixing the radius also, other than making an x-ray look different.
I've just never seen this before, and I'm just concerned that it's the DRUJ, based on the 2 images you're showing, doesn't look to be congruent now. It looks like the ulna, if I'm looking at that correctly, is very dorsal.
I mean, he had full pronation and supination. It felt like it was in place when we were moving it. It felt comparable to the contralateral side when we stressed it. I think some of the callus makes it a little deceiving. They didn't save on the AP. We did also get a more inline view of the DRUJ. I mean, everything looked okay on that view. I know the lateral looks still a little dorsal, but we did have full pronation and supination, which I can't really argue with that.
Is with peds, or is it this procedure that was an osteotomy, or is it peds routinely get casted for some time afterwards? Just because, like in adults, if you put a 3-5 with 3 screws above and below, yes, we splint them for comfort, but they essentially can start full range of motion right away. Is it?
I don't
just
really trust this kid. It depends on the kid, but this kid was, you know, out playing football with his flexi nails in, and just kind of not, and literally the day of surgery was asking me if he could go to his 7-on-7 winter workouts, which is like a week away from now. So I just don't really trust him. So he'll stay in a cast anyway, even if that was a bigger plate. Although a 3-5 plate wouldn't fit on that bone for sure.
Thank you, guys. Next is a 62-year-old female, status post. She's pedestrian struck. She's found to have this left tibial plateau fracture. Notably, this patient also had a subdural hematoma, as well as paradoxically a venous thrombosis in the brain as well, cerebral venous thrombosis. So the plan is to treat this patient non-operatively with early range of motion and toe touch weight bearing. Nice. Next, this is a 20-year-old female, status post MVC. She had her foot placed awkwardly in the car. She had this right medial, non-displaced medial mal fracture. She's placed into a short AO splint. She will be treated non-operatively.
What part of the exam are you missing?
She did it. We did have tib fib, and she didn't have a proximal injury in the fibula. Next is a 21-year-old male playing football. He said he planted and twisted, and and had a right posterior talus process fracture. This patient was placed into a bulky splint, and he'll be treated he'll follow up as an outpatient for operative planning.
What did you
You
call
have to
this
fix
injury?
all of those, Joe Mar? You have to fix every single one of those?
No, you don't have to. In some cases, if the fragment is small enough, you can excise the fragment. But I think that in this case, we would do ORIF and try and get the joint as reduced as possible. Next is an 87-year-old female, southwest ground fall of this right hip intertroch fracture. She's medically optimized, taken to the operating room the following day for a right hip intramedullary nailing.
What else does she have?
She's a lesser troch. The lesser troch is off, fractured and displaced.
Anything else? Look at her left and right rami.
Right. I believe those weren't acute. But yes, she does have a pubic ramus fracture. Next, we have a 75-year-old female, polytrauma. She fell downstairs. She sustained this left distal ulna fracture, clavicle fracture, and a zone 3 sacrum fracture. And LC1 pelvis fracture. Next, we have a 46-year-old female pedestrian struck with this right open tibia choroid fracture, as well as a tibial plateau fracture on the left. She's closed reduced. She's placed into a long AO splint provisionally, and a bulky knee immobilizer on the left knee. And then she was taken to the operating room the following morning for a right tibia IND, IM nail, a left tibia tibial plateau, or IF, and the coracoid was treated non-operatively. Thank you.
The left knee unstable?
Unstable. No, that wasn't noted in the exam, in the notes.
Was she falling into that defect?
Pardon me. Yes, for this patient, yes, she was. Sorry.
Is that ulna short, or was that DRUJ stable in the case before?
I'm saying this one. I probably could have gotten a contralateral film to confirm if that was the normal amount of shortening for her, but it doesn't look like the fracture is actually very displaced. She was able to range the joint. She really wasn't very, very painful on that side. So,
I mean, it looks like it's not displaced, but it's very unusual to see it short by that much.
That's true. Thank you, guys.
Good morning. First patient is a 32-year-old male, status post pedestrian struck, left tibial plateau fracture, closed neuro intact. CT scan was obtained. And he underwent a left lateral tibial plateau, ORIF, with some bone grafting. Next patient is a 65-year-old male pedestrian struck with a right femoral neck fracture, non-displaced, minimally displaced. Patient underwent right hip cannulated screw fixation.
How long are the screws?
What's that?
How long are those screws?
I think they're about, I think one of them's a 90, one of them's a 95. I don't remember the exact length of the screw, the other screw though.
Why didn't you put short threads in all of them? Why'd you use long threads, particularly in the one that's crossing the
Yeah, I
fracture?
agree. Yeah, we could have definitely used short threads on that on both of the other ones, but the inferior one especially, I think would have short threads would have worked out. I think we're all the way across the fracture site though. So I think these are just fine.
John, what's your risk with screw placement in the way you did that?
The risk of screw placement?
No, I said what's the risk here of complication with the way you place the screws?
Oh, it's below the lesser.
Yeah, I think that's accurate. You know, it looked worse on those on those images there, but when that screw gets too far down, it becomes a stress riser.
Yeah, I think it's right in that area.
Did you use long threads by choice, or was that you just didn't pay attention to the screws they gave you?
No, we did use long threads by choice. We knew they were long threads. Next patient is a 75-year-old male, status post fall with a right hip intertrope fracture. Underwent an MRI to confirm because on the X-rays it looked like it could have just been a greater trope fracture. And then underwent a right hip intramedullary now. Next patient is a 63-year-old female, status post fall at the beach 2 weeks prior with a right medial tibial plateau fracture. She was stable on exam. She's going to be treated non-operatively in a hinged knee brace, work on range of motion. Next patient is an 87-year-old female, status post fall with a displaced femoral neck fracture. She underwent a left hip hemiarthroplasty, cemented due to her bone quality and dorsi femur. Next patient is a 27-year-old male, status post fall from a ladder. He was a trauma. Also had a splenic laceration. He was transferred over with a right olecranon fracture, comminuted, underwent a CT scan, and was indicated for olecranon ORIF.
How'd the CT scan help you there?
The CT scan was a reconstruction of his chest, abdomen, pelvis, because his arm was in the scan. So it's not something additional that we got.
Okay.
Any particular choice? Why not put a long screw from the plate underneath the articular surface that was depressed? Well, why not do that? Like a rafting screw, the quote unquote home run screw.
We so for that we used some bone graft to disimpact the fracture, and we lagged it.
Lagged what?
We lagged the fragments together.
That plate would allow, is this I guess this is the LCP plate. Did you try to put a screw kind of subchondrally underneath or no?
John says no. Good morning. There's a 19-year-old male who fell on his inverted foots playing basketball and sustained this left subtalar dislocation. He was closed reduced and placed into a short AO splint, taken for a CT scan to confirm that there were no bony fragments. The only fracture seen is a small piece off the anterior process of the calcaneus.
What kind of dislocation was it?
Medial.
So if you couldn't reduce it, what do you worry about?
If you can't reduce it, you can have EDB or the peroneal tendons interposed, or also the joint capsule could get in there.
First patient is 40-year-old male, status MVC with right hip dislocation, acetabular posterior wall fracture, and left distal radius fracture. Patient was taken to the OR for right acetabulum ORIF, and left distal radius was immobilized in the short arm cast. Next patient is 60-year-old male, status was fall with left pelvis fracture. It was anterior column, posterior hemitransverse pattern. The patient was taken to the OR for pelvis cross reduction and percutaneous fixation. Next patient is 84-year-old male, status was fall with right proximal femoral fracture. Patient was taken to the OR for right hip, cemented hemiarthroplasty and additional greater trochanter open reduction internal fixation. Next patient is 82-year-old female, status was fall with left humeral shaft fracture. And the patient was taken to the OR for left humerus intramedullary nailing. Thank you. So there's old patients with multiple comorbidities. So we decided that minimal invasive procedure would be better for her. So there is debate between like opening the arm and put the plate, reduce anatomically and put the plate, versus put IM nail to get like mechanical stabilizations and leave biology. And we decided to proceed with like less invasive surgery.
What was wrong with the sling in this case?
It's the indication for surgery, so I'm asking, right?
So the patient's got chronic pelvis fracture. So she needs this arm for ambulation. So
Is she weight bearing is tolerated on this arm to use a walker?
She's weight bearing is tolerated on this.
You better watch her in a week or two when all of those screws back out or the nail backs out.
Yeah, the patient is going to rehab, so hopefully they will check. Thank you. That's it.